Here in Southern California, we are in an area that's endemic to the fungus Coccidioidomycosis, which is known to cause a condition called Coccidioidomycosis, which is also commonly referred to as valley fever. 60% of the cases of this infection are asymptomatic. However, the remaining 40% primarily exhibit features of pulmonary disease. Patients present with symptoms like fever, chills, and cough. However, in very rare cases that encompass less than 1% of infections, disseminated infection can occur through hematogenous spread. But these disseminated cases are most often seen in immunocompromised, diabetic, and pregnant patients. Dissemination can spread to distant tissues and cause meningitis, osteomyelitis, arthritis, and other soft tissue infections. As for this case, it highlights an important and noteworthy exception to this rule. A 32-year-old African-American man with no past medical history presented with a 3-month history of progressive swelling and pain in his left foot. On admission, the patient was found to have a mass at the head of the left fourth metatarsal, concerning for malignancy at the top of the differential, but also considering infectious etiologies and osteomyelitis. The patient is from Southern California, however, he was incarcerated at the time of presentation. Pertinent negatives on review of symptoms exam came negative for cough, shortness of breath, wheezing, weight loss, and B symptoms. On physical exam, the lungs were clear to auscultation bilaterally with no wheezes, wails, or rhonchi. And on extremities exam, there is no pedal edema, clubbing, or cyanosis noted. Radial and dorsalis pulses were 2+ bilaterally. The left foot nodule was tender to palpation and manipulation and was noted to be an exophytic mass with minimal erythema. There was absent sensation to the left foot over the area of the mass, but with no pus or drainage noted, and there were associated skin slowing in the areas of the swelling. As for pertinent labs, the patient did not present with signs of leukocytosis or eosinophilia, and actually presented as anemic with a hemoglobin of 12.5, and inflammatory markers showed an ESR of 50 and a CRP of 0.91. On imaging, which you can see to the figures on the right, on x-ray of the foot, it showed an aggressive lesion at the fourth metatarsal head, with differential considerations in favor of giant cell tumor or aneurysmal bone cyst, and later x-ray showed that there was concern for breakthrough and pathologic fracture. Also on the right-hand side in figure 3, the MRI of the foot showed an enhancing mass with bony destruction within the head of the fourth metatarsal, which we're considering a malignancy versus infectious etiology. And on the CT chest, interestingly, noted a 1.8 centimeter ill-defined nodule on the right lower lobe. At the top of our differential diagnosis, we had osteogenic malignancy, but we also were ruling in osteomyelitis. As for the patient's progress, the patient later underwent a CT-guided biopsy of the lesion, and fungal cultures later returned positive for Coccidioidomycosis, concerning for disseminated cocci. The patient was started on appropriate oral antifungal medications and is tentatively planned to have a left fourth ray total amputation for infection control. This case highlights an important example of a patient with no immunocompromising factors presenting with disseminated cocci. This patient's disease process also notably only presented with bony involvement, not with the traditional symptoms of pulmonary coccidia. And throughout the imaging workup, it's important to note that malignancy was errantly at the top of our differential, with giant cell being the likely diagnosis. We have to remember as clinicians that disseminated cocci can cause musculoskeletal involvement, with osteomyelitis being the most common finding, but typically it has a strong predilection for the axial skeleton. This case highlights a rare case of a cocci affecting extremity in an area other than the axial skeleton. And lastly, it's important to note that people of Filipino and African American descent are more susceptible to developing serious fungal infections and are disproportionately affected by disseminated cocci in comparison to Caucasians. How do we treat this as clinicians? Well, disseminated cocci can be treated with a number of antifungal medications. Azoles are currently recommended for bone and joint infections. Most commonly used is fluconazole, and amphotericin B is no longer the mainstay of treatment. The essential takeaways that we need to learn from this presentation is that this case highlights the need for clinicians to consider rare causes of osteomyelitis in patients with atypical presentations, especially in endemic regions. And although uncommon, fungal osteomyelitis should not be excluded when working up suspicious foot lesions. And it's important for clinicians to always obtain appropriate biopsies, including fungal cultures, when working up osteomyelitis. As for a question that I'd like to pose, I would like to pose the question of why is it important to do a thorough workup of this? I think that it is important to do this thorough workup because errantly we had giant cell tumor as the most likely diagnosis, which did fit the clinical picture of the presentation well. Giant cell tumors are known to be a benign bone tumor that are most often seen in 20 to 40-year-old adults, which is known to grow rapidly and destroy bones close to joints. And in rare cases, it can also exhibit pulmonary involvement through metastasis to the lungs. However, in this case, it is clear that the necessity to get fungal cultures really made a difference in the treatment of this case and ultimately led to the favorable outcomes that resulted. Thank you for listening to this presentation. I am Skylar Rains from UCR School of Medicine, and I appreciate your time.